That was an excellent talk. You're going to hear more about why we should be using cement. I do have some disclosures. I serve as a consultant and developer for Stryker, and I also have multiple leadership positions within the AJRR on the steering committee and the research project subcommittee. The goals of this talk are going to be to review the current state of femoral fixation in the United States and around the world, talk about the cement paradox that you heard just a little bit ago, which is we continue to use cementless fixation even when we know we shouldn't in advanced osteoporotic females. There's a lot of cost and morbidity associated with these periprosthetic fractures. I'll touch on that, and then talk again about some of the things you heard a bit about earlier, training gap, time, and perceptions regarding death. Clearly, we're the worldwide leader of cementless fixation in primary total hip replacement at well over 95%. I think the key question is that appropriate, and are there specific subgroups that would benefit from cemented femoral fixation? You can see over the last decade, we really haven't changed much. We're still less than 5% cement femoral fixation. Even over age 90, if you walk into a hospital in the United States, 70% of those stems are cementless. Age, sex, femoral bone quality, and surgical approach we mentioned earlier. We'll talk about the US experience, but I'll delve into some registry data from around the world to really tell us that we should be using more cement, particularly in osteoporotic older females. You can see in this year's annual report on the left that cementless outperforms cemented femoral fixation in men. The exact opposite was true in women. So we're largely talking about osteoporotic females. And most of these are due to periprosthetic fractures. One of the highlighted insights in this year's annual report was to really raise awareness about the risk of periprosthetic fractures when you use cementless femoral fixation in older patients with bad bone. This is a study by Brian Springer, who is the past president of AWS, and the senior author is Kevin Bozick, the current Academy president, reviewing AJRR data. Over 10,000 periprosthetic fractures, and they noted that cementless stems had almost a threefold increase in the risk of early periprosthetic fractures in the first 90 days. And their conclusion was, despite these data, cementless stem fixation continues to increase, including in elderly osteoporotic females, the so-called cement paradox. This is true also in Australia, so it doesn't matter whether in the US or in Australia. What you can see here is that this is totally cemented fixation, hybrid fixation, and there's almost no periprosthetic fractures. Throw a cementless stem in someone over age 80 in Australia, and you see this rapid rise in periprosthetic fractures. Notice it's not just early, this continues even later. So to avoid periprosthetic fractures in old patients, cement will really help. This is in the UK, almost a 9-fold increase in the risk of periprosthetic fractures if you use cementless devices. If you look at the experience in the UK, over time, this is just about a decade ago, they almost never put in cementless stems. Well, we taught them a little about cementless fixation. They started adopting more cementless fixation. And what you can see here a decade later, more cementless fixation. Did it help them? Absolutely not. No improvement in aseptic loosening, but a linear increase in periprosthetic fractures that closely correlated with the increased use of cementless fixation. So we didn't really do them any favors by teaching about cementless femoral fixation in all patients. This is almost 800,000 cases from the National Joint Registry in the UK, talking about intraoperative fractures. I'm not going to talk about the young patients, that's a separate group, but old sick people with bad bone using cementless implants, particularly with the anterior approach, and low volume surgeons. So you know the risk factors. Those are exactly the people we should be talking about with regard to cement. Let's talk a little bit about stem design. So if you use a blade stem in this study, you can see in A's and B's, they work great. But in door C, almost 1 in 5 are going to have a fracture if you use that stem in really lousy bone. Bad idea. How about fit and fill stem designs? This is one study out of Denmark. And in door A and B's, it works great, but in door C, a 5-fold increase in the risk of fracture compared with cemented fixation. So that really didn't help much. What about a fit and fill stem design with a collar, fully porous coated, the classic sort of Karai that's used frequently in the anterior approach, and there's a variety of other manufacturers that have similar stem designs on the market. It was almost a 2-fold reduction in the risk of fracture if you use that compared with collarless femoral stems in the UK. And this study from the United States that looked at a 5-fold reduction in periprosthetic fractures compared with single and double tapered designs, and they noticed the greatest impact in door C femurs. So we're kind of hammering home the message, old ladies with bad bone and door C femurs should probably be treated either with a fully porous coated stem design or with cement. And I would argue the vast majority are very well served with cement. The anterior approach it's been demonstrated that clearly have an increased risk of fracture in the early period, and the greatest is during the learning curve in the first, say, 50 to 100 cases. These fractures are very costly. $10,000 if you get an intraoperative fracture, $34,000 if you get a postoperative fracture. So they're very costly, and as you heard earlier, there's a death tax to be paid if these little old ladies come in with periprosthetic fractures. Big revisions tend to be older, sicker people, and some of them are going to die as a direct result of decisions we make in the operating room about optimal fixation. Totally avoidable. Cemented femoral fixation, barriers to adoption. We mentioned a little bit bone cement implantation syndrome. This is a great study out of Australia where they looked at the death tax for this. On day one, there was a slight increased risk of death, but at every other time point, all the way out to a year, a substantial survivorship advantage for cement because they're not stumbling, having fractures, and having to have big revision surgeries. So there's really not much to support that. This was a great study from Mayo Clinic, looking at 40,000 patients and looked at 23 deaths that occurred over almost a 30-year period. They were almost all in cemented hemiarthroplasties in old sick people. And what they learned was by simply adopting changes to their surgical technique, communicating with anesthesia regarding volume. So if you're going to do a cemented stem at your briefing, tell your anesthesiologist you're going to do it. Stay on top of the volume. Suck and irrigate the canal frequently. And then you don't necessarily have to pressurize the cement in these older, sicker patients. By doing those three things, they reduced their death rate threefold by making some simple intraoperative change. There's clearly a training gap. You just heard about this study earlier. It's James Brown's study from 2022. 1 in 5 residents graduating from US programs right now have seen 5 or fewer cemented stems their entire career. So they're coming out and they don't know how to use cement on the femoral side in primary total hips. On top of that, the median number of hips performed in the United States is 8. So the average surgeon out there is doing 8 a year. So they don't know how to use cement and they're only doing it 8 times a year. So we've got a real problem here. We're not training the next generation on the use of cement, and the majority of stems in the United States are done by low volume surgeon. The result's pretty predictable. Way too many periprosthetic fractures. Totally avoidable if we can train people to do it properly. So cemented fixation does require more time, and this is a big important factor, but it can be minimized with optimal technique, and frankly, it's the right thing to do with our patients. So if it takes you an extra 5 or 6 minutes on the patient who has the proper indication, it's simply the right thing to do. This is the AWS Moc exam that I had to take this year. This was one of the highlighted articles. So people at the Academy want us to know this. It's important. And the take-home message down here at the bottom, if you're over 70 years of age with Dorsey bone or you can't get good broach stability, you really should be thinking about cement. So the take-home message is cement can really help us reduce the risk of periprosthetic fractures. If you see bone like this, Dorsey canal, think cement. Do a good job. That's true of anything that we do in surgery. You still have to do a good job, get good exposure. It's a little more challenging from the anterior approach. Totally doable. You guys need to learn how to do it, and I might argue if you don't do it already at this course, maybe have a hands-on how to cement a femur from the front, in addition to just learning the slick tips and tricks on anterior approach. Communicate with anesthesia. Make sure the volume status is good before you put cement down the canal. You don't have to pressurize in old sick people. Choose a good stem. That was mentioned earlier. Maybe there's a dozen or more good stems, but go to the registries. They'll often list the top 3 performing cemented stems in the registry, a really good place to go, or look at ODEP ratings, which are free online to look for a good stem. So there's clear increased risk of periprosthetic fracture, especially in old osteoporotic females if you lose cementless femoral fixation. The risk can be mitigated with the use of fully porous coated stems with collars. I think there is need for randomized clinical trials on this to determine if we can normalize the risk of fracture by simply using a different stem. Fractures are very costly with significant morbidity and mortality. We are clearly losing the art of cement. We need to teach it again and go back to John Charnley, Robin Ling, and my mentor, Bill Harris, who taught us many years ago how to do a good job with cement technique. We need to pass it on to the next generation. Thank you for your time.